appropriately. Today, I'll share with you how to accurately diagnose this condition and how to manage them, especially in the intensive care setting. So what is Rcbis, or the reversible cerebral vasoconstriction syndrome? This is a term that I coined in probably 2002 as CVS, and then we wanted to emphasize the R. So in 2007, we called it Rcbis. It's a group of conditions, okay? It's reversible. The main angiographic hallmark is segmental narrowing and dilatation of the intracranial circle of villus arteries and their branches. And of course, the vasoconstriction also affects the distal arteries, but angiographically, that is the hallmark. It affects women 4 times more commonly as men. Consistently, the mean age in various studies is around 42 years. The cardinal presentation is sudden onset of explosive 10 by 10 pain in the head. Now, about 10% of patients don't report this, either because they can't remember it or for some other reason, like they've got a brain bleed or something else. Now, the imaging hallmark is a normal scan with the repeat thunderclap headache becoming abnormal. So that conversion from normal to abnormal is the hallmark. 60-70% have a normal scan throughout, but about 30% can develop complications such as brain hemorrhage, convexity subarachnoid hemorrhage, infarcts, or press-like lesions of brain edema. And I know that the following talk is management of brain edema. Now, the most important thing for you to remember, it's a self-limited condition with largely benign outcome. Even if people get strokes, the outcome of those types of strokes are better than other types of strokes. Now, angiographic reversal almost always occurs. In about 2% of patients, it does not occur. No specific treatment is needed except symptomatic treatment. And long-term patients do well, but they do report headache and depression, mostly because previous to the onset of Rcbis, they also had headache and depression. Now, I'm seeing a case every 3 weeks, and I've been doing so for the past 20 years. But the question is, when I ask my colleagues in India, they're not seeing it as often. So why is that? Is it a ethnic difference, racial difference, or is it something else like clinical recognition? And I suspect it's more likely the latter. Population studies have also shown a relatively high frequency. And more and more studies are coming out because we now have a diagnostic code for Rcbis, so they're able to interrogate it. Now, if you're talking about the acute setting, which is today's conclave, thunderclap headache, or many patients come into the emergency department with sudden onset of bad headache. You typically think of subarachnoid hemorrhage, but now start considering Rcbis if the patient has recurrent thunderclap headache. Okay, that's the main message for many of you today. So what is Rcbis? This is one of the first cases I saw 20 years ago. 46-year-old man with this during sexual intercourse, explosive headache. Everything was normal, although all of us thought this must be subarachnoid hemorrhage. Then we saw this arterial narrowing, segmental arterial narrowing and dilatation. You might argue that this segment is a bit more dilated. So what was this? We didn't know. We thought it could be vasculitis, could be cryptic subarachnoid hemorrhage. But he kept having bad headaches, developed some Balint syndrome, cortical blindness. MRI showed developing infarcts. We didn't know what it was, so we just watched and really let nature take its course, gave him symptomatic treatment for pain. And over the next 2 weeks, 3 weeks, his blindness resolved, the transcranial Doppler flow velocities normalized, and the MR angiogram showed reversal of vasoconstriction. So this is the typical scenario: recurrent 10 by 10 headaches, visual symptoms, strokes, and then recovery. When I started investigating this, it was like an elephant in the room, with various parts being labeled differently in the literature. Turns out that different labels in the literature included all of those listed on this slide. Drug-induced, migraine angiitis, benign angiopathy. My major contribution was to recognize that these were all nomenclatures with of the same syndrome, with the same clinical imaging findings. And I put this together as a benign condition that is not vasculitic. This is not an angiitis. Okay, This is an angiopathy or a vasoconstrictive phenomenon. And then we looked through the literature and put together a list of triggers or precipitating triggers that had been identified by clinicians when they reported these cases. So most patients did have a prior history of headache disorders, drugs and medications, exposure to hormones or tumors, but about 30% there was no identifiable trigger. So keep that in mind. Now, the point of this slide is to show you the spectrum of potential triggers. Again, this is hypothesis generating. We don't know if this is true, if there's a cause and effect, but there's clearly a very strong association because across the board, in various studies, we found the same kind of recent exposures, and everything listed here has a vasoconstrictive effect, including nicotine patches, licorice, which we have mahuang, pregnancy, the changing hormonal levels have something to do with it. So keep this in mind as you take the history in a patient with bad sudden onset headache, especially recurrent headache. Individuals don't often reveal that they've taken mahuang or they've had some marijuana, for example, but it's rather common. Ask them about over-the-counter medicines. And in India, I don't know the role of herbal medicines and Ayurvedic medicines or homeopathic medicines, so we just don't know. But it's important to keep a document and record and ask for the history. Okay, so that's the first step in history taking. Doesn't matter if it's drugs or pregnancy or something else, probably not. I did a study comparing these three classes of triggers and really didn't find anything different between the subgroups. What about the gender differences? We did explore them. Turns out that men, as compared to women, are on average, when they're affected, about 15 years younger, which is curious. Women could be Hispanic, but I've seen only one man who's Hispanic to date. This is an outdated slide now. And you can see that there's a difference in the exposures as well. Migraine, depression, and so on are much more common in women. And then clinical worsening, more common in women, typically pregnant women. So that's something to note. Now, historically, since vasculitis was first described in the early 1950s, patients with Rcbis were being treated as if they had vasculitis empirically. The main point here is that this is a vasoconstrictive, it's a chemical phenomenon, it's not inflammation. And we've done autopsy studies. This is a case published in the New England Journal of Medicine, where there was really nothing in the arteries, brain and systemic, to suggest inflammation. All we saw was this sort of more pleating in the elastic lamina, suggesting a vasoconstrictive process. What we've also done is natural history studies, and we found that there's a difference in the time course of complications. For example, brain hemorrhages tend to occur much earlier, parenchymal or convexity. But then strokes, because ischemic stroke, because of the vasoconstriction moving more proximally, tend to occur a few days later, by about day 7 or so. So keep that in mind as well. So you're on the ICU in the acute setting, bad headache, initial scan normal, another bad headache, it could signal the development of a bleed, okay? And then later on, you might expect strokes. This slide is important in terms of how long to monitor such patients, okay? So the patient comes in already with convexity subarachnoid hemorrhage, you may not need to monitor them too long. But if they're not yet, then maybe you should monitor them longer, just as a suggestion. What we've also learned is the spectrum of Rcbis is expanding. Some patients can come in with isolated thunderclap headache, benign thunderclap headache, which is a primary headache disorder. It turns out that if you image patients with just a bad headache and no secondary cause, their vessels may show abnormalities. In that case, we classify them as Rcbis. If you image the brain and they have brain edema, we call them PRES. So there's a lot of overlap between these three conditions, between Rcbis, PRES, and thunderclap headache, suggesting that there's a shared underlying pathophysiology. Some patients with Rcbis or thunderclap headache can come in with sudden memory loss, identical to transient global amnesia. In a minority of cases, the heart, and you may want to do echoes in your patients, can show reversible cardiomyopathy identical to Takotsubo. And at Mass General, we've seen curiously about a dozen patients who also had concurrent, what appears like spontaneous carotid artery dissection, SCAD. But really, I suspect that they have vasoconstriction, at least some of them, concomitant with the cerebral vasoconstriction. So the spectrum is expanding. None of us really know why this happens all of a sudden at age, let's say 42 in a woman. But we do think that there's an overlap with the primary thunderclap headache. And we think the raphe nuclei with the projection onto the surface of these brain arteries have something to do with it. And they may have more serotonin release onto these arteries, causing them to have segmental vasoconstriction. The same serotonergic abnormality can also culminate in endothelial dysfunction. We have also shown that there's SFLT1 endoglin abnormalities. Others have implicated serotonergic receptor polymorphism. So we don't really know, but these are all hypotheses. And on this slide, there are a list of references showing you how variable we are in our thinking at this point. It's also possible that there's an underlying connective tissue disorder. As we've done, we did a study comparing Rcbis to vasculitis or primary angiitis against controls and found that patients with Rcbis more often had unruptured brain aneurysms, unruptured, and that's a cause of confusion because you're seeing convexity subarachnoid hemorrhage or an aneurysm, but we have to be careful to implicate a surface bleed with a brain aneurysm. Surface bleeds are rarely because of a brain aneurysm, almost never. Okay, the brain aneurysms, when they rupture, they cause Sylvian Fisher bleeds or basal cistern bleeds. So these increased frequencies suggest that there may still be an ultrastructural connective tissue abnormality. So how do you manage such a patient? Let's say you're in the emergency department or in the ICU, patient with bad headache, normal scan, or a bit of convexal subarachnoid hemorrhage. The first thing to do is to rule out mimics, okay? Secondary causes of bad thunderclap headache, aneurysmal bleeds, okay? Is it a brain hemorrhage, venous clot, dissection of the carotid vertebral arteries, pituitary apoplexy, and certain kinds of encephalitides? A normal brain scan typically rules out all of the above. So you should do careful brain and vascular imaging in any patient with suspected with onset of thunderclap headache. Now, my colleague over at Beth Israel, Dr. Jonathan, he's come up with this algorithm, which is published in the emergency department journals. I think it's very good. Step one, brain CT. If you see something abnormal, that's the diagnosis. But if it's normal, then consider a lumbar puncture, unless the patient has multiple thunderclap headaches. Multiple thunderclap headaches are only Rcbis. I don't think there's any other condition where you get 3, 4, 5 thunderclap headache. Okay? So that you can proceed with CTA, and if it's diagnostic, your workup stops. If the patient has a single thunderclap headache and a negative CT, I think we're obligated to do a lumbar puncture. We could diagnose subarachnoid hemorrhage or other conditions. The LP is normal, then stop. Okay, then just wait and see if the patient resolves. It could be a benign primary isolated thunderclap headache. So I think this is a very good algorithm. How do you distinguish Rcbis-related convexity bleeds, which are common 30% of the time in patients with Rcbis, versus aneurysmal rupture? So we looked at this. We don't have a scoring system, but patients with Rcbis-related convexity subarachnoid hemorrhage are different. They're younger. They have a history of a prior headache disorder, depression, and COPD. On brain scan and clinical imaging and clinical findings, the Hunt-Hess grade is less. The Fisher group is much lower. Fisher group is usually 1 or 2, unlike aneurysmal bleeds where you get Fisher 3, 4. Okay. What about vasculitis? As I said, there's been a history of labeling patients with Rcbis as having vasculitis. And consequently, patients with Rcbis have been subjected to brain biopsy, empiric treatment with glucocorticoids. But really, we now know that these two conditions are quite different in terms of the character of the headache. the watershed, typical watershed location of strokes if they happen, the lobar hemorrhages and cortical convexity subarachnoid hemorrhages are very common in RCBS, extremely rare in PSCNS. There are lesions that I think are very different if you examine the brain scan carefully. Normal in many patients of RCBS. These are the watershed infarcts I told you about. As I said, you can get press and hemorrhages, which is very rare in PSCNS, as depicted on the following slide, where you see you get strokes, but look at these. These are the strokes of vasculitis. This is very different from these types of strokes of RCBS. So I think careful history taking and very careful understanding of the imaging abnormalities, as shown in this slide. By the way, this was published in Annals of Neurology. You all can read it at your leisure. So I think based upon all of this, we realize that there's a difference between RCBS and other vasculitis or arteriopathies such as moya-moya, premature atherosclerosis, or systemic or infections, radiation. So we did a study comparing RCBS with all of the other angiographic entities in the brain. We came up with this scoring system, which has stood the test of time. Published in 2019. Over the past 3 years, I've been looking at the score in all cases of RCBS, and it's very accurate. RCBS is an acronym standing for recurrent thunderclap headache, carotid artery affliction. If it's there, the top of the carotid, that's not affected in RCBS. If the top of the carotid is narrow, think of moya-moya. V is for vasoconstrictive trigger, and the two S's are for sex and convexity subarachnoid hemorrhage. This is available on mdcalc.com, and if you do it, you can see that the diagnostic accuracy approaches 100%. I don't think any other test is going to beat this very simple bedside scoring system based upon history and the admission imaging finding. That's it. You don't need any more testing. You don't need LP, you don't need angiogram, you don't need anything. Okay. So what's the implication? It gives you an accurate diagnosis upon admission. You don't need any diagnostic tests such as injection of vasodilator. It's a bad idea. You shouldn't do it for diagnostic purposes. And moreover, you don't even need to keep repeating scans because this is a benign entity. It's going to get better. My colleagues have started looking at advanced MRI to distinguish this RCBS from other entities. I think there's potential, but honestly, you can never approach a 99% accuracy as with the score. You can do this, but I don't think it's helping me because I can make the diagnosis quite easily. I'm going to end in the last couple of minutes with management. If you remember this slide, apart from the score, I think that's enough, okay, as a take-home message. Symptomatic treatment is all that's needed. Basically, take away the trigger if you identify it. Avoid doing anything that the patient is going to get better. Specifically, avoid exposing them to steroids. Don't send them for angioplasty, intra-arterial manipulation, unless you're watching and the patient has consistent clinical deterioration. This slide shows you that if you give steroids, okay, these are the steroid-exposed patients, and here's the event. Much worse with steroids as compared to without steroids. So the point is, don't try and cover your bases by giving steroids in case the patient has vasculitis. Use the scoring system and be confident that you made the right diagnosis. Intra-arterial vasodilators are being advocated by some centers as a diagnostic test. Bad idea. You don't have to take a young patient, healthy patient, and insert a catheter and poke, put contrast to make this diagnosis. It cannot be justified. This is what can happen. This is the patient who came in. She was doing well. She had significant arterial narrowing. Unfortunately, they took her for intra-arterial nicardipine injection. Great angiographic resolution. Look at this. This is the pre, this is the post. But ultimately, because of reperfusion, you can get significant damage. This patient went to the morgue. She developed a lot of reperfusion injury, hemorrhages, although she was doing well initially. So angiograms can be problematic. So to summarize, it can be easily diagnosed based upon a careful history and a review of imaging. You can use the score. Exposure to prior meds is an important part of history taking. Those meds should be avoided. Angiograms, empiric steroids, avoid. Don't try and do any intra-arterial diagnosis. Follow-up scans are also not needed. Now, recurrence of this syndrome is exceptional. Some studies say 5%, but they're talking about recurrence of just an isolated thunderclap headache. A full-blown syndrome with brain hemorrhages, etc., it just doesn't happen. Avoid vasoconstrictors for the long term if possible, but if clinically indicated, you can still re-expose them to serotonergic antidepressants, for example, and I haven't seen any bad outcome after that. If the patient gets pregnant in the future, monitor closely for eclampsia because that could be an issue. And just treat them for long-term depression, headache if that occurs, and mainly reassure the patient that nothing bad is going to happen. So I'm very grateful to Dr. Simila Fisher, Lou Kaplan, and the colleagues from Cleveland Clinic, Brazil, Turkey, and of course my parents and family for assisting me and tolerating me as I conducted this research. So thank you very much. I'll stop the share and be open for questions.
Share of cases also which may not be picking up. So is there any question, short, 2 or 3, fast? Anybody else wants to ask a question to Professor Anish, please?
I suspect many of these patients are being admitted as brain bleeds from a ruptured brain aneurysm. So I think it's important to distinguish those two, or they're being treated as vasculitis. So if you all can keep this entity in mind and avoid these common pitfalls, that'll be a big win for everybody.
Thank you very much, Dr. Samin. It was a real very nice talk where you have rightly discussed everything regarding this condition. And thank you very much once again.
Okay, all the best. I'm delighted to see the participation from the audience. Great audience. Thank you and good luck.
Thank you, sir. Now I would invite Dr. Suresh Gupta, sir, to present a bouquet to the chairpersons.
Before I present bouquet to chairpersons, because there was a confusion about tea, so we couldn't introduce chairpersons to you. Chairpersons for this session were Professor Dhanpat Kocher. He was Professor and Head of Medicine Neurology at Sardar Patel Medical College, Bikaner, and Lieutenant General Professor K.K. Singh is a Senior Consultant and Advisor in Santok Pathology Memorial Hospital. So I take this opportunity to honor them.
Thank you, sir. Thank you, sir. So next session is management of cerebral edema in acute ischemic stroke. I would invite for the chairing the session, Dr. Anjani Sharma sir, Dr. S.P. Patidar sir. I would request Dr. 𝐒𝐨𝐫𝐞𝐿 Rathod sir to present a bouquet to the chairperson. Dr. Anjani Sharma sir, he is the director of the Neurology at 𝐒𝐨𝐫𝐞𝐿 Hospital, Jaipur. And Dr. S.P. Patidar sir, he is a HOD and the Senior Consultant of Neurology at Jeevan Rekha Hospital, Jaipur.
Good evening. Now we move on to the second talk of this session on acute this management of cerebral edema in acute ischemic stroke. For that, I request Dr. Venkatesh to deliver his talk. This is a very common clinical problem which we come across in the management of acute ischemic stroke. May I request Dr. Venkatesh?
Yeah, before Dr. Venkatesh starts his talk, I would like to introduce Professor Venkatesh. Dr. Venkatesh, first of all, very good morning to you. And it's a real, indeed a great pleasure and honor for us that you could spare time to deliver talk on management of cerebral edema in stroke. Professor Venkatesh, he was the best outgoing student at Calcutta Medical College, Calcutta. Then subsequently he joined DM Neurology at NIMHANS, Bangalore, and there too he was a best outgoing DM resident. He got gold medal. Then after that he moved to New York for residency in neurology, and after residency in neurology he did fellowship in neurocritical care and worked at St. Louis, USA. Then subsequently after that at Chicago, and presently he is a professor of neurology and director neurocritical care at UT Southwestern Medical Center, Dallas, Texas. With these few words, I welcome you, Venkatesh, to deliver your talk on cerebral edema in stroke. Thank you, Dr. Venkatesh.
Thank you, Suresh. Can you hear me and see my slides?
Yes, you can.
Good evening. It's a real pleasure to be able to give this talk. I know Suresh for almost 35 years, and we've had a very strong association, and he's one of my best friends, as well as one of my first teachers in neurology. And so I'm very happy to give this talk on cerebral edema and ischemic stroke. So the topics we're going to cover today is, first I'm going to talk about the pathophysiology of cerebral edema and ischemic stroke. Then we're going to discuss the consequences and predictors of cerebral edema. And then lastly, we're going to cover the management of cerebral edema in ischemic stroke, both medical and surgical. And at the outset, I would like to state that this talk is going to be confined to large hemispheric ischemic strokes. I will not be discussing, for example, the management of cerebellar infarction, which is a whole different topic of its own. So cerebral edema, as all of you know, is defined as abnormal accumulation of fluid within the brain parenchyma, which leads to an increase in brain volume. We now currently classify cerebral edema as either intracellular edema, which is otherwise known as cytotoxic or just cellular edema, and extracellular edema. Extracellular edema is further subdivided into ionic edema, where the fluid is poor in protein, vasogenic edema, where the edema fluid is protein rich, and lastly, hemorrhagic conversion of infarctions, for example, where the edema fluid is bloody. Especially for the purposes of stroke, it is helpful to think of cerebral edema in stroke as a continuum and not think of it in isolations. And this edema has components of both intracellular and extracellular edema, starting first with intracellular cytotoxic edema and then progressing to extracellular edema, where the edema fluid is at first poor in serum proteins and then later on becomes a protein-rich fluid, and finally the edema fluid gets reabsorbed. So this slide essentially illustrates some of the current understanding of the mechanisms of cerebral edema in stroke. So in the middle here is a pictorial representation of an astrocyte, which is surrounded by sodium ions in green. Next to that is a blood vessel, and the blood vessel also contains sodium ions in green, albumin molecules in orange, and red blood cells in red. Whenever there is a disruption in cerebral blood flow, as in stroke, the first thing to happen is a depletion of ATP and mitochondrial dysfunction, which leads to a loss of the sodium-potassium ATPase pump and an inability to keep sodium ions out of the cell. In addition, there is increased expression of 3 receptors, and these are the aquaporin 4 receptor, the sodium potassium chloride cotransporter, and the sulfonylurea 1 regulated receptor. And as a result of increased expression of these 3 receptors, this allows channels to open up in the cell wall and facilitates the entry of both water and sodium into the cell, leading to cytotoxic edema. So once this has happened, the extracellular fluid is now depleted of water and sodium ions because they have entered the cell. And this leads to a gradient which facilitates movement of water and sodium from the intravascular compartment into the interstitial compartment. And these receptors, the aquaporin 4 and the sodium potassium chloride cotransporter channels, can also have increased expression in the vascular bed as well. On the other hand, if there is further injury to the vessel wall itself, there can be breakdown of these tight junctions between the endothelial cells, and this leads to extravasation of fluid, serum proteins, as well as in extreme cases, extravasations of RBCs, leading to vasogenic edema and hemorrhagic conversion. And it's important to remember that actually it is more of the astrocytes that are the major player in cytotoxic edema, and cytotoxic edema here is actually the driving force for ionic edema. Why are we talking about these receptors, and why is it important to understand this kind of molecular neurochemistry, if you would say? And the reason is that some of these receptors are now being explored as treatment targets to treat cerebral edema. So for example, 𝐒𝐨𝐵𝐿 actually blocks the sulfonylurea receptor and has been shown to attenuate cytotoxic edema. Bumetanide, a loop diuretic, blocks the sodium potassium chloride cotransporter channel. And on the vasogenic side, endothelin receptor antagonists, inhibitors of matrix metalloproteinases, as well as dexamethasone have all been tried to stabilize this endothelium tight junctions and thereby treat vasogenic edema. Lastly, it has also been postulated that the edema fluid in stroke is derived from the CSF rather than the blood vessels themselves. And a more elaborate discussion on this topic is beyond the scope of this talk, and the therapeutic implications of this are still unclear, but this is a topic of increasing research. This slide actually illustrates the time course of cerebral edema. If you look at this graph on my extreme left, this shows that autopsy studies reveal a significant increase in the weight of the ipsilateral cerebral hemisphere that happens in the first 5 days after an ischemic stroke. Similarly, if you look at the evolution of midline shift on a CT scan, it seems to peak around day 5 in survivors. However, in patients with very large infarcts and those who die from cerebral edema from stroke, this cerebral edema can occur much earlier, and you can see a peak of cerebral swelling as early as 24 to 48 hours itself. And lastly, this slide here shows the evolution of intracranial pressure increases in stroke. And again, in survivors, it seems to peak at about day 3 to 4, and in non-survivors, it continues to increase until death. Now, moving on to cerebral edema in large hemispheric infarctions, This is kind of a pictorial representation of what we're going to talk about. This is a patient of ours who had a acute left MCA occlusion and went on to develop, as you can see, a complete NCA infarct with significant midline shift, obstruction of the foramina Monro, and development of contralateral hydrocephalus. The first question that would come to mind is, why do we really care about learning about cerebral edema and stroke? And the reason is that if you look at the causes of death in stroke, among those patients who have early neurological deterioration, cerebral edema accounts for nearly half of all the causes of death in these patients. And even in those patients that do not have early neurological deterioration, 1 in 7 of all deaths is again due to cerebral edema. So cerebral edema is a very important contributor towards mortality in patients with ischemic stroke. And because this is the case, it is probably helpful for us to try to see if we can predict which of these patients are at significant risk for cerebral edema. And this slide is by no means a completely exhaustive slide, but just to emphasize some of the important predictors of cerebral edema and stroke. Among the clinical predictors, the presence of headache, nausea, and vomiting, a declining level of consciousness, dilatation of the pupil, and a high NIH stroke scale or a low GCS score are all clinical predictors that the patient is going to develop significant cerebral edema. If one looks now at the radiological predictors on a CT scan, an early hypodensity involving more than 50% of the MCA territory, the presence of a dense MCA sign, the presence of a pineal shift of more than 5 millimeters within the first 48 hours, and an aspect score of less than or equal to 7 are all radiological predictors of significant cerebral edema. There are also predictors on MRI, namely a DWI infarct volume of more than about 80 ml in the first 6 hours or more than 145 ml in the first 14 hours. And on a CT angiogram or a cerebral catheter angiogram, the presence of a combined MCA and an ACA occlusion. So once a patient has developed a large cerebral hemispheric infarction, this infarction and the consequent edema leads to several pathophysiological consequences, and it affects intracranial dynamics in several ways. So first of all, the swollen brain, through the local mass effect, will compromise the functioning of adjacent non-ischemic neurons, which leads to worsening of the neurological deficit. And as this progresses, one can start to develop herniation syndromes. And by that, I mean displacement of the brain structures from their normal location. And though classically we think of herniation syndromes as downward displacement of the brain, for example, a downward displacement of the uncus, we have now come to realize that it's actually the lateral displacement of the midbrain to the opposite side, which is probably a more important cause of the decrease in level of sensorium and even the development of pupillary abnormalities in these patients. If there is further lateral displacement, again, this can lead to compression of the foramina Monro and development of obstructive hydrocephalus, and the increased cerebral edema plus the obstructive hydrocephalus together will increase intracranial pressure, which will further decrease cerebral perfusion and lead to decrease in cerebral blood flow, worsening ischemia, and this can set up a vicious cycle. Now, one of the other questions that comes up is there any value in measuring or monitoring intracranial pressure in these patients? And if ICP is a contributor, should we be checking ICP in these patients routinely? The current evidence suggests that this is probably not helpful. I have listed here 3 early studies of ICP monitoring in patients with deteriorating large hemispheric stroke. And as you will see in all 3 studies, the ICP initially in these patients was within normal limits, even when the patients were deteriorating clinically. And the reason for this is, as I mentioned, that the clinical deterioration in these patients early on is more due to lateral displacement of the midbrain and the other brainstem structures rather than increased ICP. And if you place an ICP monitor, it really does not work as an early warning sign of worsening intracranial dynamics. And at worst, it might give the clinician a false reassurance that everything is going okay, even while the midline shift is continuing to get worse and the patient is deteriorating. The one benefit of the ICP monitor, if you want to call it, is that it does serve as an important prognostic marker in that if ICP is elevated in the setting of an ischemic stroke without effective treatment, this is associated with a high mortality. Now, next, we'll move on to the treatment of cerebral edema. And here I'm going to largely cover mainly 4 topics. First, we're going to discuss hyperosmolar therapy or osmotic therapy. Next, we're going to talk about decompressive craniectomy. Then we're going to move on to discuss hypothermia. And lastly, we're going to talk about some new therapies that are being explored in the management of cerebral edema. So first, moving on to hyperosmolar agents like mannitol or hypertonic saline. So as you know, the way these osmotic agents work is that these agents increase intravascular osmolarity. And this leads to a shift of fluid from the interstitial compartment to the intravascular compartment, and thus decreasing brain volume and thereby decreasing intracranial pressure. Now, underlying all this is the assumption that the blood-brain barrier should be intact in order for this to happen. The commonly used osmotic agents, at least in the United States, are mannitol, which is available in concentrations of 15 to 25%, hypertonic saline, which is available in concentrations of 3% all the way to 23.4%. Nowadays, we're also using buffered 3% hypertonic saline with sodium acetate instead of purely sodium chloride to try to obviate the hyperchloremia, which some of these patients have that has been associated with renal failure. Glycerol is used in Asia and some European countries, but it's not used in the US for treatment of cerebral edema. And below that, I have listed some of the equivalent osmolarities of these substances. So 20% mannitol is more or less equiosmolar to 3% sodium chloride, and they both have osmolarities of around 1,000 milliosmoles per liter. Now, what is the rationale for using osmotic therapy in ischemic stroke in the first place? And this has been an area of controversy, and there are both cons and pros for the utilization of this treatment. People who argue against the use of osmotic therapy would say that global ICP elevation, as I discussed before, is really not a major cause of early worsening in ischemic stroke. So why are we trying to use an agent that primarily works to lower ICP? We also know that for osmotic agents to actually work, the blood-brain barrier has to be intact. So mannitol and hypertonic saline will predominantly shrink the unaffected hemisphere. They will not actually work to reduce the volume of the infarcted cerebral hemisphere. Some people have also postulated that where the blood-brain barrier is broken, there may be a theoretical risk that these agents might be accumulating in the infarcted tissue and might theoretically worsen the infarct volume. And lastly, the available studies do not support a mortality or outcome benefit with the routine use of osmotic therapy in ischemic stroke. On the other hand, all of us have seen evidence of reversal of signs of herniation. For example, a dilated pupil becomes constricted again with a dose of mannitol, as well as improvement in the Glasgow Coma score with osmotic therapy. There is anecdotal evidence and case series of patients with large ischemic stroke that have improved with osmotic therapy, and I'm going to give you some examples of that in the 2 subsequent slides. And lastly, mannitol has been postulated to improve blood viscosity and potentially improve blood flow to the brainstem that has been displaced by the infracted hemisphere. And this might be another mechanism by which these agents work. So this paper is an example of the use of osmotic therapy in patients with large hemispheric stroke. So this study looked at 30 patients with large hemispheric infarcts with a median NIH stroke scale of 19. And they showed that about 47% of these patients survived with just osmotic therapy alone. And as you can see in this graph, the lower the NIH stroke scale score, the better the chance of medical management. But even as you can see, there are some patients with an NIH stroke scale of around 30, and some of them survived just with osmotic therapy alone. And some of the factors associated with success in this study were black race, the presence of a lower NIH stroke scale score, not requiring osmotic therapy in the first day, and patients that required a lower dose of hypertonic saline. This is an example of one of my patients with a large MCA infarct. You can see that 60 hours after the onset, this patient has a midline shift of the septum pellucidum of almost 10 millimeters. This patient's family did not want hemicraniectomy, and this patient was treated with osmotic therapy. And you can see that 3 weeks later, the midline shift has almost completely resolved, and this patient actually recovered and went home. So there are definitely some of these instances where osmotic therapy works. The challenge is trying to figure out in which patient osmotic therapy alone will work and which patient will need something else. So I thought I'd also cover some of the general principles of the use of osmotic therapy. So first of all, I would like to emphasize that there is no role for prophylactic use of osmotic therapy in every patient with ischemic stroke. I use it only for patients who show some evidence of clinical deterioration with radiological worsening in the form of increasing midline shift or worsening sulcal effacement. We do not routinely use it in every single patient with stroke, even in those that have a slight degree of midline shift but are clinically stable. Second, whenever you use any form of osmotic therapy for more than 48 hours or so, the treatment should always be tapered before stopping, and do not stop osmotic therapy abruptly, because this will lead to a risk of rebound cerebral edema. Third, do not use hypotonic maintenance IV fluids in these patients. Don't use half normal saline. Don't use 5% dextrose water, as it defeats the purpose. You're trying to make the blood more concentrated, and using dilute solutions is actually going to work against you. Fourth, whenever you use osmotic agents, and especially mannitol, which is a powerful osmotic diuretic, always keep an eye on their intake and output and maintain euvolemia. The goal is to keep the patient hyperosmolar and not to make the patients hypovolemic. Hypovolemia will lead to potentially a drop in blood pressure and a further drop in cerebral blood flow, which we want to avoid. And then lastly, be aware that because of a generation of idiogenic osmoles by the brain, when you use osmolar therapy for a prolonged period of time, as time goes on, you may need to use progressively higher doses of the substance in order to maintain the same effect, because the brain increases its osmolarity and the previous doses of mannitol will no longer be effective. When we use mannitol, If the patient has evidence of acute herniation, usually large doses are administered. We would give a rapid IV infusion of 1 to 1.5 grams per kilo. The commonly used maintenance doses are in the range of 25 to 50 grams every 4 to 6 hours. Generally, in the setting of large hemispheric infarcts, we would use it for about 5 or 7 days, followed by a taper over in the next 2 to 4 days. You need to watch for some of the side effects of mannitol, and these might include electrolyte disturbances like hypo and hyperkalemia, hypomagnesemia, and hypophosphatemia are again quite common. Very rarely, you can also see hemolytic anemia from mannitol. Use it very carefully in patients with heart failure because acutely mannitol is going to act like a volume expander and can potentiate acute heart failure. And also avoid using mannitol in patients with renal insufficiency as it is renally excreted. And if you don't monitor it carefully, then you will have progressive accumulation of mannitol in the blood. And we have actually had 1 or 2 patients who developed hyperosmolar coma, not from the stroke itself, but from the inappropriate use of mannitol. Many textbooks actually recommend monitoring osmolarity when using mannitol, and they say that you should keep the osmolarity between 310 to 320 milliosmoles per liter. There's really no strong evidence to support this practice, and if needed, mannitol can be used with targeting much higher serum osmolarities than these numbers that I have quoted, provided that you make sure that all the mannitol that you've given has been completely excreted before you give the next dose of mannitol. And the way we do this is by monitoring the osmolar gap just before each dose of mannitol. And because mannitol is an unmeasured osmol, this osmolar gap acts as a surrogate for the mannitol level. So the osmolar gap, as you remember from your internal medicine days, is calculated by sending a measured osmolarity to the lab and then calculating the osmolarity from your sodium, BUN, and glucose. And the measured osmolarity minus the calculated osmolarity will give you your osmolar gap. And generally speaking, an osmolar gap of less than 20 would indicate that all the mannitol that you have given earlier has been completely cleared, and it's okay for the patient to get a next dose of mannitol. And if the osmolar gap is higher than 20, we should probably delay the dose by an hour or 2, and the next dose should probably be smaller than the one that you've given before. Recently, we are using more and more of hypertonic saline rather than mannitol. And when we use 23.4% saline, 0.7 ml of 23.4% saline is equiosmolar to a gram of mannitol. So if you want to give about 50 grams of mannitol, you can convert that and it works out to about 35 ml of 23.4% saline. So the commonly used doses are 30 to 50 ml of 23.4% saline. If you don't have this concentration available, if you have only 3% available, the commonly used dose is about 250 ml of 3%. So some of the advantages of hypertonic saline over mannitol are that one is it can be used in renal insufficiency. It is useful when when a volume expansion is desired, for example, in patients with traumatic brain injury who also have other organ injuries. It has probably a little bit of a less of a diuretic effect than mannitol. And monitoring hypertonic saline is definitely easier than mannitol. You don't have to worry about osmolar gap. One of the main disadvantages, especially if you're using 23.4% saline, ideally you would like to have a central line placed. Some physicians use continuous infusions of hypertonic saline rather than giving bolus doses. I believe that continuous infusion is not really supported by our understanding of how we think osmotic agents work, and that continuous infusions may actually promote synthesis of 𝐒𝐤𝐥𝐻 osmoles and may favor the movement of solutes into the brain. So generally, we do not use continuous infusions of hypertonic saline unless we are treating hyponatremia, which is a completely different subject. And when we use hypertonic saline, we try to keep the serum sodium less than 160 milliequivalents per liter. If you go above that, then this becomes an independent predictor of mortality. And as far as the clinical relevance between the choice of hypertonic saline to mannitol, in some studies, the use of hypertonic saline has been associated with a lower ICP of about 1 to 2 millimeters of mercury. Whether this is of practical relevance or not is really unclear. We usually look at other factors such as how easy it is to give, whether the patient has central venous access or not, whether the patient has renal insufficiency or not, to decide whether we're going to choose hypertonic saline or mannitol. Now let's move on to surgical treatment, which is decompressive craniectomy for these patients with large hemispheric stroke. And before that, it's helpful to just review the modified Rankin scale because it'll help us understand some of the questions that come up when offering these patients hemicraniectomy. So modified Rankin scale of 3 means that the patient has a moderate degree of disability and requires some help but is able to walk unassisted, whereas a modified Rankin score of 4 means the patient is unable to walk, unable to attend to their own bodily needs without assistance. So these are the 2 that are going to be important when we talk about in the subsequent slides. So recently, there have been several studies looking at the effect of decompressive hemicraniectomy in these patients. And physiologically, it would make sense that if you take off the skull on the side of the infarct, the edematous brain would bulge out of the craniectomy site and not press on the normal hemisphere. And there have been several trials that I've listed here. Essentially, most of them enrolled patients between the age of 18 to 60, except for Destiny 2, which enrolled patients greater than the age of 60. The time of onset of decompressive hemicraniectomy in these trials varies to between as early as within 24 hours to as late as within 96 hours. Various NIH stroke scale criteria, various imaging criteria, either more than 50% or 2/3 of the MCA territory had to be involved, or in those that used MRI, a DWI volume of more than 145 ml, and an outcome of either modified Rankin score of 0 to 3 or 0 to 4 at 6 months was considered to be a good outcome. And if you sum the results of most of the major trials, what you will see is that this is actually the distribution of the modified Rankin scales at 6 months. So early decompressive craniectomy, which is craniectomy done within 48 hours, as opposed to pure medical treatment, decreases mortality by 50%. So it'll drop your mortality from 75% all the way down to 30%. But what is important is to note the very important influence of age on this outcome. And this is a number that I like to remember and quote when I discuss statistics with my patients, that if you have a patient who's less than 60 years old, for every 10 surgeries that we do, we will save 5 lives. And out of those 5 lives saved, 1 patient will end up with a modified Rankin score of 2, which is a very good outcome. 1 patient will end up with a modified Rankin score of 3, which is not bad, and 3 patients will end up with a modified Rankin score of 4, which is not that great. However, in patients above the age of 60, for every 10 surgeries, you will save only 3 lives, and out of those 3 lives, 2 will end up with a modified Rankin score of 4, and 1 with a modified Rankin of 5. And this flowchart explains how we approach this when we talk to patients. So we ask ourselves in the family 2 questions. 1, what is the patient's age, and 2, what is the quality of life that would be acceptable as a good outcome to the patient and the family. So let's take the best case scenario, which is the patient who's less than 60 years of age, and the patient's family says that an MRS score of as high as 4 is acceptable to them. So in this patient, hemicraniectomy has almost 70% chance of giving them a good outcome. On the other hand, if you look at the worst case scenario where you have a patient more than the age of 60 and the family says that for them, the only acceptable good outcome would be an MRS score of 0 to 3, for that patient, you have a less than 10% chance of offering them that scenario. So this kind of helps paint a picture both for us and for a family to decide whether the patient should or should not be taken for decompressive hemicraniectomy. Now moving on to hypothermia, this is something that showed early promise, but recently there have been several trials of hypothermia and stroke that show that hypothermia can be achieved and maintained, but there seems to be a high risk of pneumonia with these patients. And also, addition of hypothermia to hemicraniectomy does not improve mortality and has a significantly high and probably unacceptable adverse event rate. So this is kind of falling out of favor. Lastly, to talk about a new therapy that's on the horizon for cerebral edema. As I mentioned earlier, glyburide given IV antagonizes the sulfonylurea 1 receptor, which is thought to be very important in mediating cerebral edema. So the 𝐒𝐿SRP was a randomized, double-blind, multi-center phase trial, which enrolled patients with large hemispheric infarcts. This trial was concluded prematurely because funding was pulled by the drug company that sponsored the trial, and the trial did not meet its primary outcome measure, but there seems to be a signal towards improved survival in these patients that got the IV glyburide, as well as an improved midline shift in these patients that got IV glyburide compared to placebo. So this is a treatment that is potentially promising, and ongoing studies are being continued both in stroke and in traumatic brain injury. Lastly, just to go over the acute stroke guidelines. So these are the American Heart Association and American Stroke Association guidelines. So they recommend that use of osmotic therapy for these patients is reasonable. They do not recommend the use of hyperventilation, hypothermia, barbiturates, or steroids that I did not talk about. They say that it's reasonable to use decompressive craniectomy in patients that have a decreased level of consciousness. It is slightly has a stronger evidence in patients less than 60 years of age, not so great in patients more than 60 years of age. The European guidelines are also similar, strong strength of recommendation with moderate quality of evidence for hemicraniectomy in patients aged 60 years or younger. Again, not that great in patients older than 60 years. And similarly, they do not recommend the use of corticosteroids or hyperventilation. And the expert consensus statements states that we should not routinely use osmotic therapy, but we may consider it as a short-term, as a rescue procedure in cases of increased ICP or impending herniation. And they also suggest the use of bolus administration rather than continuous infusion. So lastly, just as take-home points, the pathophysiology of cerebral edema is still evolving. Cerebral edema remains a major cause of mortality in stroke. The peak period is around 3 to 5 days earlier in young patients and with larger strokes. Hemicraniectomy is a life-saving intervention, but the impact on functional outcome needs to be discussed with families in great detail, especially in patients who are more than 60 years of age, in order not to substitute mortality with severe unacceptable morbidity. There is a limited role for osmotic therapy in these patients, and IV glyburide is one of the treatments that is being currently studied. I'll thank you for your attention, and I'm happy to take any questions that you might have.
Thank you, Dr. Venkatesh. Summarizing this lengthy topic from pathophysiology to treatment and neuro aspects. Cerebral edema is common monster for all of us after 2 to 3 days, and our patients are fighting with cerebral edema. So you summarize it very well. Thank you, Dr. Venkatesh. Thank you for this.
Comments or questions from audience?
Sir, good morning. Just I wanted to know, in your practice, supposing a young patient is there with MCA infarct, you wait for him to deteriorate within 48 hours or prophylactically you plan for decompressive surgery? Thank you.
So that's a very good question. So if you look at the hemicraniectomy trials, they did not wait for clinical deterioration in these patients. So first is we would look at the infarct volume, and the data would suggest that if your infarct volume on a diffusion weighted MRI image, if that volume is less than 140 ml, then that patient will not need hemicraniectomy and that patient will do fine. If the hemicraniectomy volume is greater than 200 ml, if you do not do hemicraniectomy, that patient will die. So there's really no point in waiting. In between the area of 145 to 200 ml, again, the trials would show that hemicraniectomy has significant survival benefit, and at least some of them will have a good modified Rankin score. So for a young patient with an infarct that is between 145 and 200 ml, if the patient is sleepy, we would take the patient for hemicraniectomy. We would not wait for him to have a pupillary dilatation before we take the patient to the OR.
I am Dr. Sridhar from Enhance. So what is the reason why this glyburide study was withdrawn, and why the funding agency stopped the drug, and who was the funder?
Sorry, I couldn't hear you properly. I know you're trying to ask a question on glyburide. I didn't understand the rest of it.
Essentially, what was the reason the study was prematurely withdrawn, and why the funding agency withdrew the study when the initial result was favoring the primary outcome?
I cannot answer on the basis of the pharmaceutical company. I am not, I do not know what their finances were. I don't know why they said that they ran out of funding. But again, it did not meet its primary outcome measure. So there was not a statistically significant outcome benefit that they had originally powered their study for. So maybe the drug company just wanted to have enough data so that the further larger trial would not have to be sponsored by them, but would be sponsored by the NIH. Drug trials in the United States are very, very, very expensive.
Any other question?
I think there are no more questions, and thank you, Venkatesh. Thank you. I think there.
Hello. Good evening, sir. I just wanted to ask about hyperosmolar therapy. Is there any added advantage of adding both together? Like if the patient is already on mannitol and you don't find in early 24-48 hours patient to be improving, and adding 3% saline over it, and if you are using only 3% saline, the guide to continue or to discontinue, would that be sodium, or in that case also you go according to the osmolarity?
So there are two separate questions. I'll take the second one first. So if you are using hypertonic saline, your calculated osmolarity will be very close to your measured osmolarity because there are no unmeasured osmoles in the blood. So you can monitor the amount of osmotic therapy that you're giving to that patient just by looking at their serum sodium concentration alone. You don't need to separately check for osmolarity. Unlike mannitol, where it is the mannitol itself that is increasing your osmolarity, and you have no way routinely to check mannitol levels. And the first question was, is there a benefit in adding the two? So we usually will add the two. For example, you gave somebody, started off with mannitol. You gave him, let's pretend that you have an Icp monitor, and this is not a patient with a stroke, but a patient with a head injury. So you gave him 75 grams of mannitol because the ICP was 30, and the ICP came down, but then 2 hours later, the ICP went up again. And at that time, the osmolar gap is still 40, so there's still mannitol in the system, but the patient's ICP is high, and so you don't want to give another dose of mannitol because then that'll just lead to accumulation of mannitol. So in that patient, instead of giving mannitol at 2 hours, we would give hypertonic saline. So we would use hypertonic saline in between doses of mannitol to allow the mannitol to be excreted, but at the same time provide some extra hyperosmolarity to treat the patient. As far as whether there is clinical benefit to the strategy or not, again, there are no studies that look at combined use of mannitol plus hypertonic saline and compare them to either mannitol alone or hypertonic saline alone. So we would only use it in situations where you think that one drug alone is not effective, mainly for toxicity reasons rather than clinical efficacy reasons.
So for using hypertonic saline alone, the sodium target, what you keep is that's 155 or 160 serum sodium?
So anything above 160 is been associated with increased mortality. So we generally target our sodium between 150 to 155 because, again, it is not very easy to titrate to a very exact sodium level. So if I want my sodium to be 159, I cannot always achieve 159 if I want to get it as high as possible, but not cross the 160 threshold. So generally, if we are already reaching the 155 range, we will probably try to back down on that.
Thank you, sir.
Hi, Dr. Venkatesh. Good evening. Since you are a neurosurgeon also, I would focus my question on the neurosurgical aspect. As you said, that early surgery within 24 to 48 hours, and you divided the age less than 60 and above 60. Above 60, you said if MRS3, the chances of improvement in 8% of the cases of 3 MRS. Now, early surgery means what do you mean by early surgery? In what cases early surgery within 24 to 48 hours to have good results? Because this will be your decision of surgery would be based on many factors. Level of consciousness, deteriorating level of consciousness, ICP, CT scan showing shift. So is it that with all these standardized criteria of surgery remaining same, and then early surgery or late surgery? So what is the takeaway as an indication for early surgery?
So first of all, I'm not a neurosurgeon, even though I'm a neurologist and a neurointensivist, even though my faculty appointment is with neurosurgery. So in general, patients who need surgery would probably benefit from that surgery if done early, as opposed to if done late. The downside of that is doing early surgery means that you may be taking some patients to the operating room that might do okay even without surgery. So we look at a lot of different factors, and as I said, in my slide, so there are some clinical predictors as well as radiological predictors that would tell us that this patient has a very high likelihood of developing large cerebral edema. And these include things like young age, very large 𝐒𝐈 stroke scale, decreased level of consciousness, a complete MCA occlusion, early midline shift of more than 5 millimeters in the first 48 hours, and an infarct volume of more than 145 ml in the first 14 hours. So in the first 14 hours itself, if we can do an MRI and we can show that this patient has a very large infarct volume, this patient will have a very high chance of getting worse. So in that patient, if that patient is sleepy and not awake and alert, we would take the patient to surgery early, before 48 hours, and not wait for them to get worse to the point where they start, having herniation, pupillary dilatation, extensor posturing, so on and so forth. Does that answer your question?
Yes, I think to the large extent, because you had shown one slide in one of your patients who did not want surgery with a quite significant midline shift.
Yeah.
And
again, this is right, and that's, this happens. And even on the other hand, even among those who have hemicraniectomy, you still have a 20% mortality. So surgery doesn't save everybody, and medical treatment doesn't kill everybody. So there's always that gray zone, and that's where, sometimes we have to use our clinical judgment and experience. And even then, in some cases, we're not perfect, and we make mistakes.
Thank you. Thank you so much.
Thank you very much, Dr. Venkatesh, for excellent interactive session. Now we conclude this session. Thank you.
Thank you, sir. The next topic is recent developments in management of ICH by Dr. Neha Dangayach, ma'am. I would like to invite for chairing the session Dr. Dilip Maheshwari, sir, and Dr. Sushil Tapadia, sir. I would request Dr. Yashpal Rathod, sir, please chair the session.
Yeah. Good morning, Dr. Neha, and thanks for joining from New York. Dr. Neha Dangayach is a consultant neurologist and director neurointervention at Mount Sinai Hospital, New York. She will be talking about recent developments in intracerebral hemorrhage. Now I hand over to Dr. Sushil Tapadia and Dr. Yashpal Rathod for further proceedings. Thank you.
Good morning, Dr. Neha. And after listening since morning about the stroke, ischemic stroke, and surgical management of ischemic stroke as well as the hemorrhagic stroke by Dr. Daljit and so many other topics we have discussed. Now, what recent is going on in the management of intracranial hematoma? So, you are most welcome, Dr. Dangayach.
My name is Neha Dangayach. I'm a neurointensivist at the Icahn School of Medicine at Mount Sinai in New York, New York. I'm the Systems Director for Neuroemergencies Management and Transfers, and it's my honor and privilege to present to you on one of my favorite topics, ICH. I did serve as a peer reviewer for the American Heart Association ICH guidelines, which I'm going to reference quite heavily in my presentation today. So diving right in, for hemorrhagic stroke, when we think about SAH and ICH, about 15 to 20% of all strokes are going to be hemorrhagic strokes. And just like for all medical emergencies, ABC is always going to come first. Blood pressure control, reversal of coagulopathy, what diagnostic imaging do you need, neurosurgical consultation. These are very similar between what we do for SAH and ICH. And for aneurysmal subarachnoid hemorrhage, patients tend to be younger. For ICH, when we talk about primary or spontaneous ICH, these patients tend to be middle-aged or older. And a couple of things to keep in mind about blood pressure. For aneurysmal subarachnoid hemorrhage, prior to their aneurysm being secured, we are currently following this blood pressure goal. We're saying SPP less than 140. Based on the latest AHA-ICH guidelines, we are changing our practice now for an SPP goal of 130 to 150 for ICH patients. Going back to the similarities between the two, glycemic control, fever prevention, DVT prophylaxis, anti-seizure medication prophylaxis and treatment, preventing, treating different medical complications, multidisciplinary team management, instituting early, but not ultra early, not within the first 24 hours, but early rehab after 24 hours, leveraging shared decision-making, preventing therapeutic nihilism, and screening for multi-domain impairments is common to both SAH and ICH patients. In terms of the mechanism of injury, in the first 6 hours, we're really looking at the effects of that primary neurological injury. That hematoma and that expansion of the hematoma is going to happen. Early expansion is seen in a majority of the patients who are going to undergo hematoma expansion in the first 6 to 12 hours or so. And we know that with this expanding hematoma, increase in ICP, hydrocephalus, and if that remains untreated, then the potential for herniation. Beyond 6 hours, it's usually the drivers for neurological injury are secondary neurological injury, cerebral edema, inflammation, toxicity from blood products. So as a general principle to keep in mind for acute ICH management, these are all the different mechanisms that are targeted. In terms of the etiology, that's what determines the ICH location. For the purposes of this talk, we're talking specifically about primary ICH or spontaneous ICH, where there's no underlying vascular malformation. For example, AVM, dural AV fistula, aneurysms. We're not going to be talking about those secondary causes of ICH. We're going to focus on primary or spontaneous ICH, which commonly occurs because of small vessel disease. 80% of these bleeds are going to be deep, about 20% are going to be lobar, and when they're deep, they're usually because of arteriolosclerosis or small vessel disease, and lobar ICHs are usually because of cerebral amyloid angiopathy. These are the common locations for small vessel disease, basal ganglia, cerebellum, pons, and thalamocapsular region. So just keeping that in mind, the American Heart Association ICH guidelines divides the guidelines into different phases of care for ICH, the emergency acute care, inpatient course, rehabilitation and recovery, as well as secondary prevention. With improvement in ICH mortality, the focus is really moving towards improving ICH survivorship and providing multidisciplinary care and screening for multi-domain problems. So here are some class 1 recommendations for where should we initiate appropriate life-sustaining therapies. This is ABC. This should happen as soon as you see the patient. Time is brain, we've got to move fast, right? Providing care in a specialized unit, leveraging a multidisciplinary team, intensivists, neurosurgeons, endovascular specialists. If a specialized unit is not available, then transferring these patients to centers that have that kind of capability. And then particularly for patients who have ICH with IVH and hydrocephalus, making sure that they have access to a neurosurgeon who can place an EVT rapidly. Not a lot of changes here with respect to the baseline history. We're all familiar with this, and the guidelines just lay this out in a nice graphic. The ICH volume is a good volume to calculate the moment you get that scan, because it's going to help determine candidacy for certain kinds of treatments. For example, minimally invasive clot evacuation. The ICH score, of course, is derived from the volume of an ellipsoid, ABC upon 2. And it's also important to get a baseline severity score. Now, that baseline severity score, there are several recommendations in the AHA-ICH guideline statement that talk about obtain that baseline severity score It can help guide management, but it should not be used in isolation of other factors for limiting life-sustaining therapies. One key thing to keep in mind is, should you get a CT angiogram? On that CT angiogram, you may pick up a spot sign. Even on that non-contrast CT head, you will pick up certain signs, for example, hematoma with irregularities at its margins, that help you identify which patients are at a higher risk of hematoma expansion. This is a class 1 recommendation to get a rapid CT or an MRI. This is important for determining your underlying diagnosis. So there are no questions about that. Now, should you do a CT angiogram or not? This is variable. It's variable because it depends upon how high your suspicion is for finding an underlying vascular malformation. So you could use a score like the secondary ICH score to risk stratify patients. And then utilizing markers both on the non-contrast CT head as well as that CT angiogram, for example, the spot sign, to identify which patients are at a higher risk of hematoma expansion. Then comes the question of monitoring patients for stability. We know that a majority of the patients who are going to suffer from hematoma expansion will have that hematoma expand in the first 6 to 12 hours. So the recommendation is to get at least your first stability scan around 6 to 12 hours from the first one, and you could repeat another scan if you see hematoma expansion on that scan. In terms of the diagnosis and assessment, of course, there's an interesting recommendation about venogram. It just makes me wonder, it really depends upon the underlying clinical suspicion for whether somebody has sinus venous thrombosis or not. I do completely understand about getting a CT angiogram to understand whether somebody has an underlying vascular malformation or not. And for those patients in whom the clinical suspicion for having an underlying vascular malformation is high, diagnostic conventional cerebral angiogram is recommended. Diagnostic as well as potentially therapeutic. Now, shifting gears to blood pressure control, this has been a slightly controversial area, intensive versus standard treatment, two large randomized controlled clinical trials, which predominantly guide our current understanding of blood pressure management. There have been several post hoc analyses from both these studies, as well as several other cohort studies, smaller trials that also inform our understanding. In both INTERACT, which was a European study, and in 𝐒𝐴𝐸2, which is an American study, there was no difference in the primary outcome of improving functional outcomes. However, a key thing to keep in mind is there was a signal towards improving functional outcomes in INTERACT-2, but not in 𝐒𝐴𝐸2. So while both these trials did not meet their primary outcome measure, we did infer from them that to prevent hematoma expansion, perhaps intensive blood pressure control is okay. And specifically in follow-up studies after INTERACT-2 and 𝐒𝐴𝐸2 and some post-hoc analysis, this is more important. It's not just that absolute blood pressure number, but how quickly that target is achieved. So the recommendation is to reach that target within an hour. And medication titration to ensure smooth control rather than fluctuations is important. And this is a key change. If somebody has an ICH that is mild to moderate in severity, then and presenting with a blood pressure of more than 150, you don't want their blood pressure to be dropped to lower than 130, because that has been associated with harm, for example, infarcts. And for patients going to that 130 to 150, in patients with mild to moderate severity, presenting with a blood pressure of 150 to 220, acutely lowering that blood pressure goal to 140 is fine, but they also give you this range, 130 to 150. For us, it's important to put that in our titration instructions so that bedside nurse knows what to do with that trip. Anti-thrombotic related ICH. These patients tend to have worse outcomes as compared to patients who are not on antithrombotics or anticoagulants, particularly. And failure to reverse the INR within the first 2 hours is an independent predictor of mortality. Lots and lots of different agents, just taking a look at vitamin K antagonists and direct oral anticoagulants, and then target specific oral anticoagulants. In this meta-analysis from lots of different studies that looked at the incidence of hemorrhage, you can see that it favors target specific oral anticoagulants. The general approach for vitamin K related ICH, we just want to stop that agent what is the underlying reason why a patient was on that agent is important to help determine how aggressively you can reverse their coagulopathy, and then when can you potentially restart it. Vitamin K, and then whether you're going to use FFP, PCC, there's some data to guide us on the choice. So what is that underlying reason? Reversal choices could be FFP versus PCC, different kinds of PCCs, 3-factor, 4-factor. The key thing that I wanted to share was, of course, the volume that's administered with PCC is much lower as compared to FFP, cost higher as compared to FFP. I have the cost down here in dollars, but I'm sure the cost is still high in the Indian settings as well. So just something to keep in mind. And then for direct oral anticoagulants, should we really use Andexanet or not? Fairly controversial currently, and I'll show you what the AHA recommends on that. For patients who are on Pradaxa using Fraxbind or idarosuzumab, and then 4-factor PCC versus plasma, and for patients who've been on DOACs, again, there is some hemostatic efficacy with 4-factor PCC. So here's what the AHA says: discontinue the anticoagulant therapy, rapid reversal should be performed as soon as possible, using PCC based on INR and vitamin K. For dabigatran, like we discussed, is Fraxbind available or not? If not, use PCC. This is the controversial part of this infographic. The body of the guidelines don't say it in the same way, that if Andexanet is not available, only then you should be giving PCC. So just something to keep in mind. We are still at our center debating whether we should even put Andexanet, just given how costly it is, and the data that is informing Andexanet's this particular recommendation in our mind was not as strong. And then for heparin, of course, you'll reverse it based upon the timing from the diagnosis of the ICH and when they were on heparin and the underlying indication for heparin. Just a couple of words on platelets and whether you should give patients who are on platelets or not. So based on patch, we know that that was published in Lancet looking at platelet transfusion versus no transfusion in patients with ICH. Only in those patients who are going to undergo neurosurgical procedures, it may be reasonable to give platelets. That's been our approach since patch was published. And then DDAVP, because DDAVP does not have a lot of side effects, it may be reasonable to give patients who are undergoing procedures DDAVP. There's of course going to be one, maybe more randomized controlled clinical trials in the near future that will inform our understanding of whether we should use DDAVP or not. I already mentioned this, for anti-seizure medications treat seizures, but if there's a low clinical suspicion of seizures, avoid anti-seizure medications. Now let's dive in the last part of the talk into surgical techniques. Should we remove blood? How should we remove it? And when should we remove it? The when is more controversial. How, we have more data. Should we remove? In my mind, absolutely, if a patient is the right candidate. Surgical interventions, open surgical, craniotomy, hemicranie, suboccipital cranie. Here, multidisciplinary decision-making, shared decision-making with the patient's family, making sure that this decision is aligned with their goals, values, and wishes. For minimally invasive techniques, lots of different techniques have been studied. Pharmacological catheter-based techniques, just inserting a catheter, putting in a thrombolytic medication into the hematoma cavity. Image guidance to place that drainage catheter or irrigating that catheter continuously with lytic solution. Mechanical, using an endoscope or an exoscope with or without a catheter for drainage. Lots of these different strategies are currently being either have been studied in small RCTs or are being currently studied. So lots of evolution in data for minimally invasive clot evacuation. In MISTI-3, this randomized controlled clinical trial that looked at minimally invasive surgery along with thrombolysis did not meet its primary outcome, which was improvement in functional outcomes. So MISTI-3 did not meet its primary outcome, but in those patients who had residual hematomas that were less than 15 cc's, there may be some suggestion of improvement in functional outcomes. So in meta-analysis that include MISTI-3, but also include other RCTs of minimally invasive evacuation, there's been an improvement in mortality. In MISTI-3 as well, improvement in mortality. However, functional outcomes may not improve with, have not been found to improve with currently studied methods of MIS. Yes, patient selection is very important. Supratentorial ICH, hematoma volume of more than 20 cc's but up to 30 cc's, and a lower GCS. Going to IVH with CLEAR 3, although CLEAR 3 did not meet its primary outcome measure, there was mortality reduction. So you could still consider giving thrombolytics through that EVD. Placement of EVD, no doubt, no question. Patients who have hydrocephalus, IVH, they should get EVDs. And whether we should administer thrombolytics via the EVD, again, we determine it at our center case by case. For supratentorial ICH, this particular recommendation is really informed by Stitch 1, Stitch 2, some smaller studies, as well as studies that have looked at decompressive craniectomy being a life-saving surgery. So craniotomy for hemorrhage evacuation is a life-saving measure. It may not necessarily be a quality of life adding measure. So it may not improve functional outcomes. For cerebellar ICH, on the other hand, there's more data to suggest, and it's a class 1 recommendation, that immediate surgical removal of the hemorrhage plus minus EVD to reduce mortality is recommended. Any ICH that has a volume of more than or equal to 15 cc. So this recommendation is the same as the prior 2015 guidelines. Here's just a picture of SCUBA, a technique that was developed at Mount Sinai by Dr. Christopher Kellner. It's called SCUBA because it's evacuation using an endoscope underwater. That's why the word SCUBA. And we pretty much changed our care delivery paradigm, our systems of care, to cohort and triage patients who are eligible for SCUBA to an ICH-focused hospital. And in this study, we had 90 patients undergo inter-hospital transfers out of the 100 we included, and only 10 were admitted directly via the ED. What we showed in this paper was by having a centralized system of triaging patients, so by leveraging NEMAT, we were able to improve access to a novel therapy for ICH. In this retrospective cohort study, again from patients who had undergone SCUBA, we did find time is brain. The faster we evacuate the clot, the better the outcomes. This needs to be studied in randomized controlled clinical trials. The key message from this set of recommendations from the AHA, essentially using a baseline severity scale is recommended, but that should not be used in isolation to limit life-sustaining therapies. And this key recommendation on aggressive care should be continued. DNR should not be instituted until at least 2 days of the hospitalization have been completed. This comes from a lot of studies that looked at how DNR becomes a self-fulfilling prophecy in ICH patients in the US. For rehab and recovery, just like for acute care, multidisciplinary rehab is highly recommended. Instead of ultra early rehab, of course, ultra early rehab is associated with worsened outcomes, but early rehab is recommended. And then in patients, fluoxetine, which used to be after flame, used to be a therapy that was promising to improve neuronal plasticity, was studied in multiple RCTs, affinity, effect, flame, so on and so focus, which all showed that these patients do not benefit from fluoxetine. In fact, there may be some adverse events such as fractures, osteopenia, seizures, etc. Hence, fluoxetine to promote motor recovery is not recommended. However, if somebody is on fluoxetine for depression, for their underlying depression, that should be continued. For neurobehavioral complications, screening patients for these complications is extremely important. Class 1 recommendation for depression, anxiety, cognitive impairment. The screening tools can be used for then connecting patients with the right resources and therapies, and referring patients to cognitive therapy, as well as continuation or initiation for pre-existing mood disorders of SSRIs is also recommended. Now, should anti-thrombotic agents be restarted? Going back to that idea that ICH survivorship is improving, and these patients have a whole bunch of different cardiovascular comorbidities. So what should the right strategy be? About 20% patients with ICH will also have underlying atrial fibrillation. Should they really be on anticoagulation? Should they be on aspirin? This is being studied in a lot of different RCTs, including an RCT that we are participating in called ASPIRE. ASPIRE specifically looks at apixaban versus aspirin. There are a whole bunch of different studies that are looking at the same question. For patients who have a high risk of a thrombotic event with who are on mechanical circulatory support or who have a VAD, in those patients, early resumption of their anticoagulation may be reasonable. Otherwise, we're waiting for about 2 weeks or so. In my summary slides, I just wanted to show you a snapshot of all the different kinds of targets, therapeutic targets. So ICH is no longer a disease that we don't have treatments for. There are a lot of different targets for treatments, both in the acute phase as well as in the longitudinal phase. There are lots of promising therapies which are being currently studied, which will move from the preclinical phase to translational phase and into clinical trials as well. So time is brain. Keeping all these things in mind can truly improve patient-centered outcomes. And with that, I'd like to say thank you for this opportunity. And here's my acknowledgement slide specifically to our patients and families, because they are the reason why we do everything that we do. Very grateful to my team members, and particularly Drs. R.P. Sarwal from Wake Forest, Dr. Kellner, and our neuro ICU pharmacist, Nicole Davis, for allowing me to adapt some of their slides. And the AHA slide deck that I use several slides from is also a very useful slide deck to keep handy. Thank you. I look forward to the questions.
Thank you, Dr. Neha, and very nice presentation. Now, any questions from the audience? Hello. Sorry, Dr. Neha, she has to go in emergency, so she will not be available to answer your question.
Sir, one second. Dr. Surendra, please come on the stage. To present a bouquet to the chairperson.
Now I invite Dr. Tarachan Joshi and Dr. Arun Agarwal for chair the session. Tarachan Joshi and Arun Agarwal.
Hello.
Dr. Neha has joined back and she is happy to take few questions.
Hello from New York. Sorry, I was running behind. I'm on ICU service, so I'm looking forward to your questions, and thank you so much for the invitation.
So, hi, Dr. Neha. In your slide, you mentioned that in patients who have a high risk of recurrent thrombosis, like mechanical heart valves, we have to start anticoagulation early. So my question is there any definition of early, or is it relative? And second is, which agent would you put them on? Would you put them on LMWH, or would you put them directly on anticoagulants? So that is what is my question.
Excellent questions. I think our approach to restarting anticoagulation for patients on mechanical circulatory support or patients who have VADs or who are on ECMO, etc., will typically do this in a multidisciplinary fashion. We'll speak to the heart failure team, our neurosurgical team, the ICU team, stroke neurology. All of us will determine what is the risk-benefit ratio. The earliest we have done this is about 5 days. One conservative approach that I don't have a lot of literature to support, but I can say that one conservative approach that we've used is we start a low dose heparin drip without a bolus, and the PTT goal will be about 50 to 70 or 60 to 90. And as soon as somebody becomes therapeutic, we'll repeat a CAT scan and see if that underlying hemorrhage is stable or not. So that's been one approach. We typically don't start them on full dose, for example, putting them either on warfarin right away, at least confirming that the hematoma doesn't expand after getting that stability CT head once they are therapeutic has been our approach. Again, like I said, this is not like literature driven, it's more we've got to have multidisciplinary consensus. What the AHA guidelines say that you can start it early. They don't typically define what early could mean, but as early as 5 days would be okay.
Thank you.
Thank you so much.
Can you just enlighten about the SCUBA technique and what is the early outcome? SCUBA.
Absolutely. So SCUBA was named because of how the hematoma is evacuated under sterile water or sterile saline, and it's cold water, cold saline that's used. And our neurosurgical team, so Dr. Kellner and team developed this. What they do is typically take the patient to the endovascular suite. Early, when SCUBA was being developed, we would wait for a stability scan. So that 6 to 8 hour scan, make sure the hematoma is not expanding, not take a patient to SCUBA if their CTA shows a spot sign, because we know that there's going to be some active bleeding, etc. However, with more experience now, there have been patients who have benefited from direct cauterization of active bleeding while evacuating the hematoma. So essentially what's done is the patient will go to the endovascular suite with an endoscope. Previously, there was this Apollo catheter which was being used. There are other newer catheters which are being used now, and it will be inserted under direct visualization right to the bottom of the cavity of that hematoma. And the hematoma will be sucked out from the bottom up, and then the cavity will be examined with this cold, sterile water, sterile saline to look for any active bleeders and whether the hematoma cavity shows good evacuation or not. Sometimes Dr. Kellner and team will also use intravascular ultrasound. They've also described this endoscopic vascular ultrasound to also take a look at whether there are any vessels, etc., and what is the hematoma cavity looking like after evacuation. That's not done routinely in every single case. The case selection with respect to the criteria that the AHA mentions, having a hematoma volume of 20 but less than 30 cc's or so. We've also started taking patients who have hematoma volumes of 15 cc's or higher, but less than 30 cc's. And then NIH stroke scale is also factored into, and their baseline modified Rankin, to make sure that somebody has a good functional baseline before they go in for this procedure. So typically patients who have a baseline modified Rankin of 2 or higher will be considered, 2 or lower will be considered for SCUBA. Early results from our cohort, good functional outcomes. In fact, in those patients, so a couple of things when we looked at a comparison of our cohort to what the MISTI 3 cohort looks like, the patients had a much better outcome, overall function. There's improvement in mortality, as well as the proportion of patients who are achieving a modified Rankin of 0 to 2 is also higher. The hematoma evacuation with residual hematomas of less than 15 cc, so more than 85% cases were achieving hematoma evacuation of less than 15 cc. So overall, it's been quite beneficial. Right now, it's not a randomized controlled clinical trial. It's a cohort study. So it obviously has selection bias. In the latter half of our cohort, we have been more cautious in including patients with underlying renal disease or underlying hepatorenal dysfunction, because those patients tend to bleed more.
Those are patients achieve MRS less than 2. MRS less than 2, how many percentage of the patients have achieved?
So I want to say most of the cohort right now. So SCUBA has been done in almost 160 to 170 patients. Most of the papers that we published have been on cohort sizes of, between 90 to 100 or so. So the proportion of patients that achieve that MRS ranges between 30 to 40%, depending upon the cohort selection. Thank you.
Thank you, Dr. Neha. This is Dr. Suresh Gupta from Jaipur. I'm really, indeed grateful to you for sparing time to join us.
No, thank you so much. It's my honor and privilege, and I'm sorry I was running a little bit behind. First day on service, so it's always tricky.
Though you were on emergency services, still you could find time and join us for this meeting. Thanks a lot.
No,
and
absolutely,
we are indeed
absolutely.
grateful to you.
No, thank you, much appreciated.
Thank
Congratulations on a fantastic conference. Take care.
Now I invite Dr. Madan Mohan Gupta for delivering his talk. He will be telling about his experience at Eternal Hospital about neuroimaging and neurointervention. He is a consultant neurointerventionist at Eternal Hospital, Jaipur. Over to you, Dr. Gupta.
And patient hearing. So I will discuss regarding the role of the neuroimaging and
recording in progress
and its interpretation and use for the therapeutic role as a neurointervention. So the goals of the acute stroke imaging, as we are hearing since morning, there are 4 P's like parenchyma, pipe, perfusion and penumbra. So that goal has to be achieved either by CT scan or MRI. If you are comfortable to diagnose and treat on the basis of CT or CT angio, that's good enough. No need for the MRI. If you are confused, if you are not sure, then definitely you have to take the better imaging modality like MRI. So everybody knows that this yellow part is the ischemic core, and we have to save this blue part, penumbra. So in the imaging modality, NCCT, non-contrast CT, MRI for the vessels, CT angio, MR angio, DSA, carotid Doppler, and perfusion images. So everybody knows that the CT scan has been used for the exclusion of the hemorrhage. And if we can find out this hyperdense MCA, that would like to assure that this patient may need intervention. If we will delay, then there is definitely formed infarct after a few days. So the imaging should be read on the basis of the territory, just like ACA, MCA, PCA, or posterior circulation, like cerebellar, 𝐒𝐿𝐴, 𝐴𝐵𝐿𝐴. And if there is a watershed infarct, that will give the different hemodynamic compromise that the patient may have any occlusion, restrictive lesion, occlusive lesion from the arch of aorta to the brain. So now I will share my experience over here in the neurointervention. This is a case of the 65-year-old gentleman. He had a stroke on the 31st August on his retirement day. His power was 0/5 and NHS was 15. He immediately rushed to the hospital from the nearby place, around 120 kilometers. He did CT scan over there, and it was showing hyperdense MCA on the right side. Aspect was 8 to 9. This was the clinical picture at the time of the voice. Okay, he is having gaze paresis, you can see, and he is obeying commands, but moving only right upper limb and right lower limb, not the left side. So we took this patient directly to the cath lab without wasting time. So door to needle time was less than 20 minutes and door to reperfusion time, DTR, was 45 minutes. We did cerebral DSA. On the DSA we find that the occlusion of right internal carotid artery from its origin, there was no circulation in the brain from the right side. We started mechanical aspiration thrombectomy with the strand retriever and aspiration catheter like this. We try to grab the clot, and final result was this. The whole 𝐡𝐤3 flow in the MCA, all the branches are filling up. This was the clot has entrapped into the strand retriever, and this is the post-procedure CT. You can see small infarct on the right MCA territory, especially basal ganglia and the insula, and small reperfusion bleed in this area. This was the clinical recovery. After 45 days, he can walk, as well as he showed us I can run also. So we were very happy. He is a doctor. Now he is practicing himself also. He is a 65-year-old gentleman. So this was the first case. Another case, 54-year-old gentleman came in the 3 hours, right MCA stroke on the diffusion weighted MRI. We did DSA. There is a tight stenosis over the right ICA origin with the distal thrombosis. There is a T occlusion after the ophthalmic artery. Complete recanalization, 𝐡𝐤3 flow. We didn't stented it because it was the acute stage. We did angioplasty, and after that, after 6 weeks, we did stenting. This was the clot, and this was the CT scan, very small infarct. This was the recovery after the procedure, just after the procedure in the ICU. Another lady, she came in wake-up stroke, just like we are discussing today regarding the mechanical thrombectomy for 24 hours. So according to the Dawn trial, this patient was entered into this scan. The NHS was 17, wake-up stroke, and there is a small infarct. Only the infarct is forming over here because of a good collateral. So on the CT angiography, there is a complete occlusion of the common carotid artery from its origin. There is no ECA, there is no ICA, but there is a good collaterals try to forming from the left side and the ACA as well. After the DSA, we did the mechanical thrombectomy. Whole right ICA as well as the MCA has opened up, and this was the clot, and this she is the female. Now she is doing good activity. She is independent. All the scans were good. So this was the corona time. Our thank you to our team who did the best effort in that time also. Now the posterior circulation stroke. This patient did recently. Thank you for a colleague who sent this patient on a time to save a life. So this was the infarct in the cerebellum. Medulla was spared. Small infarct in the pons, and there is no big infarct. The complete occlusion of the basilar artery, no vertebral artery was filling. We immediately took this patient also in cath lab. This was the patient presentation. He was altered sensorium. We intubated him immediately because his response is M3 only. We did immediately mechanical thrombectomy, right vertebral artery is occluded completely. So this was the clot, and we retrieve it from this one. And next day in the ICU, the patient is following command, extubated, showing his tongue, moving both the upper limbs as well as both the lower limbs as well. So this was the posterior circulation because on the time did the mechanical thrombectomy, bilateral vertebral arteries were occluded. So now carotid stenting. Everybody knows that if there is a occlusion in the origin, at the origin of the right ICA or any of the ICA, it may cause hemodynamic stroke distally. So this is a 53-year-old gentleman, right-handed, recurrent TIA in the left MCA territory. This was the tight stenosis on the ICA. We did the stenting, and this is another case. I want to emphasize on the use of the filter because we did this carotid stenting and we entrapped this clot in the filter. So if we would have not used this filter over here, spider, this can cause MCA stroke during the procedure. I have encountered 3 to 4 patients in which the clot has been trapped in the filter, around 30 patients. Intracranial stenting in acute stroke. This patient came from Kota after 16 hours of the stroke. Same, this is the internal watershed infarct. Patient was having aphasia and right upper limb weakness. This was the 𝐡𝐤𝐿 over here, and this is the distal MCA. We did DSA, loaded, and after that, we put a stent over here, and there is a complete recanalization TK3 flow. Patient was lifting her right upper limb as well after the procedure. So in the case of recurrent TIA, this is a left middle cerebral artery and the distal internal carotid artery, significant critical stenosis. We did angioplasty stenting after failure of the best medical management. Patient is doing well. This is the basilar artery. There is a occlusion as well as the stenosis. We did a stenting and angioplasty over here also. This was the cases from the ischemic stroke. Now I will tell about the subarachnoid hemorrhage, hemorrhagic stroke. So this is a grade 4 SAH. This is the coiling, balloon assisted coiling, stent assisted coiling. He presented with the SAH, right side ptosis also. 2 aneurysms were there, right PCOM as well as the right anterior choroidal artery. Both were taken up same time and both the coiling were done immediately. Patient is fine. This is the wide neck ACOM aneurysm. Also coiling was done safely. This is the aneurysm which is incorporating more than 280 degrees of the artery. So it is very difficult to put a coil over here and very difficult to place a clip also. So we did a reconstruction with the stent and we put a coil after that. This is the wide neck aneurysm. We did the flow diverter treatment for this. This is the wide neck. So this is the flow diverter which has been placed over here. She is doing good. This is a case where the lady presented with the right side third nerve palsy, and this was the large right cavernous IC aneurysm. Flow diverter was placed, and after the 6 months, patient has partial improvement in the ophthalmoplegia and nearly good recovery in the ptosis. This is a recent case where the patient presented with the epistaxis. Her hemoglobin was 5 only because of this hemorrhage in the sphenoid sinus. This aneurysm was ruptured, and you can see there is a small aneurysm over here also. So this artery was dissected over here. We did coiling as well as flow diverter. After that, this nasal packing was removed. She is doing good. Her life is saved. This is a 46-year-old gentleman presented with the seizure as well as the left-sided weakness. There was a right subcortical parietal hemorrhage. On the investigation, we found that there is a dural AV fistula, and we embolized with the onyx, and he is doing good. He is now able to walk, and power is around 4/5. This is a interesting case. This patient came with the recurrent episodes of headache. He was having this CT scan since last 2 years back. Then he came to present it to us in our OPDs, and we did an MRI. In MRI, we showed that on the red arrow, there is some flow voids, as well as on the diffusion weighted images, there is some hyperintensity. We suspected it may be a venous ischemia, or it may vein of Laue infarct, vein of Laue sinus thrombosis at that time, and maybe possible it is a dural AV fistula over there, and we can see right IJV thrombosis over here. So we did angiography directly, and we found this is a dural AV fistula. Diagnosis was made, and concurrently the onyx embolization was done. He is doing good. Embolization, complete curable embolization of dural AV fistula. This is the cerebral AVM. It was also embolized. For the epistaxis, if it is a straight segment, we have placed the stand graft also. For the carotid cavernous fistula, coiling can be done, and it is easily salvageable for the vision loss. And this is a spinal dural AVF glue embolization. These are the flow voids where we found out, and then we did the angiography, and after the spinal DSA, all the feeders were occluded and the complete cure of the spinal dural area. So in the Eternal Hospital since 2.5 years, from the 15 Jan to 15/7, 2020 to 2022, our team has performed 436 procedures, in which the diagnostic was cerebral and spinal DSA was 292, therapeutic was 144, and in which the ischemic stroke interventions was 80 and hemorrhagic stroke interventions 64. So it was done under the leadership of Dr. Suresh Gupta sir, Dr. Sushil Tapadia, Dr. Yashpal Singh Rathod, Dr. Surendra Khoshia, Dr. Arun Agrawal, Dr. Tarachand Joshi, and team Neurocritical Care and team Neuro Rehabilitation. Of course, emergency, radiology, and cath lab team are always there, and I am thankful to the Eternal family for giving me this opportunity, and we are doing the work which is shown by the Zurich doctor also, and we are doing in Jaipur also. Thank you.
Thank you, Dr. Gupta. You have presented large number of cases from your intervention, and you are doing excellent work. I congratulate you for over 400 cases and a high success rate. Now the floor is open for any questions. So there is no question. We end up the session here.
Other than the diffusion flare mismatch, we can use any other imaging modality or any mismatch like flare vascular hyperintensity, diffusion flare, diffusion bedded imaging with versus SWI mismatch. Can we use as a marker for thrombectomy or thrombolysis?
Yes, yes. For the diffusion flare mismatch as well as SWI flare mismatch, yes, both can be used, because SWI can show the collaterals. If there is a good collaterals on the SWI images, that patient can be taken for the intervention, the outcome will be definitely good. So don't go directly on the diffusion flare, always look on the SWI also, because it can guide you regarding the reperfusion bleed as well as for the outcome of the patient.
Or any specific guideline that we can directly patient ship to the cath lab if we suspecting large vessel occlusion without CT, or we can do CT in cath lab?
This study is going on. After some time, the cath labs are the first place to do the CT scan. If patient came with the acute ischemic stroke within the window period, patient can be taken into the cath lab, do a CT scan, vaso-CT, exclude the hemorrhage, do a angiography over there. If there is a large vessel occlusion, do a mechanical thrombectomy, so it will give definitely good outcome. If there is a small vessel occlusion, you can give a IVT, intra-arterial TPA, so that will also helpful. But the guidelines has not come yet.
Any trial is ongoing if a patient came in out of window period or after 24 hours of the acute stroke onset, but patient imaging shows diffusion flare mismatch, large vessel occlusion, good collateral, then could intervene these patients with mechanical thrombectomy? Any trial or any study after 24 hours?
I am not aware. After 24 hours,
because patient show diffusion flare mismatch, good collateral, then definitely can be helped.
For that, I can say like this, most of the patient, if they are preserved after 24 hours, it means that there is a less infarct or more penumbra, definitely. If they are showing their watershed infarct, if there is significant ostial or the occlusive lesion, definitely the stenting or angioplasty or revascularization helps them immediately.
Now I invite Dr. Tarachand and Dr. Arun Agrawal to present a moment of Dr. Madan Mohan Gupta.
Thank you very much all. Now I invite Mrs. Manju Sharma ma'am to
deliver vote of thanks to all the delegates and the speakers. Thank you.
Good evening, everybody. And I welcome Dr. Dharkar, definitely. I'm seeing him after a long time. I think today's roller coaster ride has completely your brainstorming. You people have done a lot. And thanks to my neuroscience team under the leadership of Dr. Suresh Gupta and his team members. Believe me, all these team members, they put our vision in reality. And that's what it matters. And I have seen Dr. Madan so many times, witnessing his effort to save or salvage the patient. And I always thought, okay, heart attack, you have golden hour, and you save the patient, you say, wow, voila, you did it. But congratulations, Dr. Madan. I have witnessed and I'm in cath lab so many times to see how your effort and your dedication and that consistent effort to save the patient. It's congratulations, and I want you to go further. And you have a lot of good team members, and you have excellent mentor here, Dr. Suresh Gupta. And I definitely would like to see good luck to my team members in neurosciences, and keep on doing good work. And thank you for coming. And I think it's a lot of brainstorming today. People should enjoy the evening. Thank you.
Thank you, madam, for your words of blessings. And I take this opportunity to welcome Professor Dharkar, patron of neurosciences in Rajasthan. He was instrumental in starting neurosciences, particularly Neuro Surgery, in the state of Rajasthan. Now it's a time to announce the results of Neuro Stroke quiz. We had two modes of stroke quiz, virtual as well as those who were present physically. So the online participant, the first prize goes to Dr. 𝐒𝐤𝐿𝐵𝐿𝐿𝐵𝐿𝐿 Please give a big round of applause to him. The physical mode, the first prize goes to Dr. Pankaj Sharma, and second prize goes to Dr. Deepali. Please give a big round of applause to all of them. And now I request Professor Dharkar Sahab to say a few words and few words of blessings and present prizes to the winning candidates. These are the residents, sir, from Icp Medical and other institutions. Welcome, sir.
Thank you, madam. Thank you, Suresh, for inviting me here. And I'm extremely honored to be here again. And it's my proud privilege to welcome all of you, though I couldn't come in the morning because of some problems. But a lot of things are happening here, and neuro team here is doing extremely well. Excellent work they are doing all the intervention procedures, neuro care, ICU happenings, OTs, and everything are doing very well. I always keep on hearing, see their results, they are at par with everyone all over the globe. So again, I congratulate all of you over here and all the best wishes for further and future progress to all of you. Thank you very much.
I invite Dr. 𝐒𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿𝐵𝐿
Now I request Mrs. Manju Sharma, MD, Eternal Hospital, to present, to hand over the award to Dr. Pankaj Sharma. Thank you, ma'am, and thank you, Pankaj. Now I call upon Dr. Deepali to receive the prize, and I call Dr. Prachish, CEO of Eternal Hospital, to hand over the prize to Dr. Deepali. Thank you, Dr. Prachish. Thank you, Professor Dargar Sahab, and thank you, Manju Madam. Now I request Dr. Rajesh Prakash, is the CEO of the hospital, to say a few words and vote of thanks to all the participants, pharmaceutical colleagues.
Thank you, Dr. Suresh. I think it has been a wonderful day, and as expected, the day has been attended by well-deserving faculty from neurosciences. I'm here it's a very proud moment for me to tell all of you that there has been a lot of good work that all of us have been doing in the last 2.5 years. The team that has been built up at Eternal Hospital has been built up under the leadership of Dr. Suresh Gupta as the chairman of neurosciences, and Dr. Sushil Tapadia, who is the chairman for neurosurgery. The team has been built up, it has been handpicked by Dr. Suresh, and the team is clearly deserving a lot of applause from us. I think it is very, very apt to say that for the kind of work that the team deserves, for the kind of recognition that the team deserves, all of you are here. And for every bit that the team has done, it did require to put on stage what all things they have done, what are we up to. Thank you all for being here. You all have come here, and that's a great, great encouragement for the team. It is also a hallmark that we stand for each other. If there is a good work that is happening, that good work is happening for all of us. We stand for each other, we encourage each other. Thank you all for being here. The residents have been here. The faculty has been there. There are senior people who have been here. So thank you so much. And I look forward to all of you encouraging the team as always. Thank you so much.
Thank you, Dr. Prashish, for your kind words. And I take the opportunity to thank each one of you, all eminent speakers, my colleagues, Dr. Sushil Tapadia, Dr. Yashpal Rathod, Dr. Surinder Khosea, Dr. Tarachand Joshi, Dr. Arun Agarwal, Dr. Madan Mohan Gupta, and our very energetic marketing team under the leadership of Mr. Nitesh Tiwari, other supporting agencies, and pharma colleagues, Micropharma, Intas, Sun, Abbott, and all other pharma colleagues. Though without their help, this event could not have been taken place. So please give them a big round of applause. Yes. And now I request all of you to please stay back for gala dinner. Thank you so much.